one of my oldest friends and my first campaign volunteer when I ran for mayor in 2003, turned out to have become severely bipolar. He had gone off to college and was a young man. And his parents and I was a mayor at the time, we tried to do everything we could. And after about a year and a half of battle, we lost him. He committed suicide. And so I think almost everyone, I'm sure everyone in this room, but almost everyone in our universe has examples like that of people that they've known of the intensity of the tragedy and how people become transformed. But I think often we don't think enough about those people that when we get to them and we intervene and they struggle and they go through sometimes many months and even sometimes years, but then they turn the ship around. And I have two members of my extended family, cousins, who both had severe challenges, were suicidal for a long time, and got around the corner. And you know, they will still have battles, but one in particular has just had a remarkably fulfilling life. And we can make a difference. You know, suicide is a tragedy that affects thousands of individuals and families per year. In Colorado, it's more than 3 Coloradans per day. The data came out that Dr. Wolk and CDPHE released from the Office of Suicide Prevention that showed that we had a noticeable increase in the rates since 2009 in Colorado, so 18.6 per 100,000. More importantly, I think it's Colorado has been consistently in one of the 10 highest states in terms of suicide. It is part of our healthcare fabric. We've made a big effort we're the thinnest state, but we need to be the healthiest state. And this is a big part of that. I think this forum is exactly part of what the solution is making sure that we have opportunities of engagement where people that are willing to put the time in can expand to their own networks what the possible benefits are.
No one wants to talk about suicide. No one wants to believe it happens. No one wants to, let alone deal with it, either in the workplace or with family or friends. And trying to find a cohesive, aligned, preventive solution or solutions is difficult if we can't talk about it. So this year I sponsored Senate Bill 88, which will create a public-private commission to advise the Office of Suicide Prevention regarding suicide prevention priorities and policy and funding in Colorado. It's the first of its kind to build public-private relationships to create the synergy and resources necessary to tackle this public health crisis in our state. So business leaders, as you have your staff meetings or walk in your hallways and you see your employees, remember that none of us truly know what is going on in the inside. And when you look at your spreadsheets, your benefit plans, and ROI, please know that you are not only the financial steward of your employees' futures, but you can also have a profound effect on their well-being and perhaps even save their lives.
Hello, I'm Pam Hyde, Administrator of the Substance Abuse and Mental Health Services Administration, or SAMHSA. SAMHSA's mission is to reduce the impact of substance abuse and mental illness on America's communities. Suicide prevention is one of SAMHSA's highest priorities, and SAMHSA is proud to support efforts such as the National Action Alliance on Suicide Prevention, a public-private partnership with more than 200 participating organizations. We're also proud to have worked with the United States Surgeon General to create the National Strategy on Suicide Prevention. Today you will hear workforce representatives from the military, from the corporate world, from professional sports, and from suicide attempt survivors, all working to prevent suicide and promote behavioral health in all kinds of workplaces. Best wishes for a wonderfully productive meeting and the inspiration to take your experiences into your own workplace to provide for the health and safety of workers everywhere.
I had an opportunity to dive into suicide in ways that few people ever get to. I commanded twice in Iraq. I spent 24 months in Iraq, 2004, 2005, I took the 1st Cavalry Division over. A total of about 50,000 folks worked for me during that time. I had one single suicide out of 169 soldiers that I lost. In 2006, I was the operational commander in Iraq, had 145 to 150,000 folks working for me, and our suicide rate went up. I came back to the States and worked for Bob Gates for 17 months, traveled to every single hospital in the United States military, both abroad and at home. And it wasn't until I became Vice Chief of Staff that Medical Command came into my office one day and put a slide down in front of me. And that slide showed that the most prolific wounds that we had coming out of this war were not people who had been shot or blown up or had, in fact, lost an arm, a leg, or multiple limbs. It was, in fact, people with traumatic brain injury and post-traumatic stress. And I'm embarrassed to tell you, I did not know what traumatic brain injury and post-traumatic stress was. I spent 4 years, the next 4 years of my time as vice, as much time as I could spend trying to educate our force about traumatic brain injury and post-traumatic stress and learn everything I possibly could. At the same time, the Army suicide rate had doubled since 2001. We had gone from 10 per 100,000, which was 1/2 the civilian suicide rate, to just over 19 per 100,000 in 2009. And the Secretary of the Army and the Chief of Staff of the Army asked me to lead a task force to try to reverse that trend. Now I'm going to throw a little cold water on what you're going to be doing here in the next couple of days, because I'm going to be telling you that there are a lot of programs that can help, but there aren't enough, because we don't know enough. We don't know enough about the human brain. I think you know in the Army we have certain advantages that you all don't have. We have a very captive employee base. And when we want to teach suicide prevention classes, we can bring in the experts, and we did. We brought in the best experts we had. We looked every commander in the face. We made him put it on his official form that he would be graded on, that he had the responsibility to lower the suicide rate in his unit. But we didn't see a lot of movement. I had the ability to do a full-up 15-6, that's an investigation on every single suicide that happened in the United States Army. And from 2009 until I left in 2012, every single suicide was briefed to me, the Chief of Staff of the Army, the Vice Chief of Staff of the Army. And this is what we found out. I don't know how many of you know we have medical examiners, and every time we have a death in any one of the services, the same group of medical examiners go out and make a death determination. I would argue our numbers are pretty good, because in every single death in the services, you've got a single group of individuals applying the same standards that are going out and making a death determination. So the 349 or the 160 to 180 I was seeing in the United States Army, those are pretty good numbers. And here is the statistic that brings me to where I am today. In 4 years of having every single suicide briefed to me in the United States Army, between 160 and 180, between 49 and 51% every single year had gone in and sought help for the problem that they had. That, to me, was an amazing statistic. Somebody would throw up and show me where a doctor, and we had strict rules in the Army on how we did this, if you were considered a threat to yourself or somebody else, an immediate threat, you were required to be put into an inpatient program. But I can't tell you how many times I saw a medical record of a young individual who killed himself 24, 48, 72 hours before, and clearly written by the doctor as this individual is no threat to himself or anyone else. Yet 48, 72 hours later, they committed the ultimate act. I tell everybody, if you have traumatic brain injury or post-traumatic stress in this country today, it's kind of like having a heart attack in 1930 or going to see a cardiologist in 1930. That's where the state of the science is right now. And the reason the state of the science is right there now is because we do not share databases in this country when we fund research projects. Now, that's going to be hearsay to some of the folks in here who are going to say, whoa, where are you going, General? Well, I have dedicated my retirement to trying to change that, to find better diagnostics and treatments for traumatic brain injury and post-traumatic stress. And if you know anything about post-traumatic stress, you know that the comorbidities associated with post-traumatic stress are general anxiety disorder and depression. And if you know anything about suicide, you know that many of the individuals who commit suicide have depression. If we're going to get beyond suicide prevention programs to really understanding the biology of what when somebody does this horrible thing, when you have a person like Robin Williams who understands he has a problem, has the means to get the help, gets the help, but still commits suicide, you've got to ask yourself, what do we have to do to unlock the secrets that can help us really get at this problem and stop it from happening?
So over the next few minutes, Dr. Quinnett and I would like to kind of round out your understanding of suicide in the workplace and suicide prevention. Among the age group that you're employing in your businesses, it's the fourth leading cause of death. 4.5 times now people in that age group die by suicide that then die from HIV, and more than twice as many in that age group again die by suicide than homicide. When we look at the whole population, there are more suicides than motor vehicle deaths, and prostate cancer, which is the most prevalent cancer among men. Suicide takes about 25% more lives than prostate cancer, and just a few less lives than breast cancer. And when you think of all the research money, a little political comment here, that goes toward prostate cancer and breast cancer, which we're all pleased with, there's just a tiny fraction of that that is going towards suicide. So among adults, again, the people that you employ, we've got about 38,000 suicides. For every suicide, there's about 20 attempts or so. Many of those are hospitalized or seek medical attention, which costs money, not only lost productivity, but actually dollars to pay for the cost. And then there's about 200, 250 people for every suicide. These are people, many of them are working in your businesses, and they are sitting there with serious thoughts of suicide. This is kind of looks at the actual numbers of people who die by suicide by age group. And you can see that the vast majority of people in this country, and again, I'm sure in Canada as well, are people who are in the workforce. And so this issue hits those of you who are running businesses and employing people. Suicide costs dearly families and businesses in both an emotional toll and an economic toll from what is left behind. But suicide, there is no single cause. We know that there are scores of factors that increase one's risk for suicide. And there are scores of factors that decrease risk for suicide. But none of the risk factors is sufficient enough to cause a suicide. So it's this complex interplay between risk factors and protective factors that unfortunately sometimes results in someone taking their life. So I would like to just take a couple minutes and highlight some of the effective strategies that I think business leaders need to consider. And again, keeping in mind that effective suicide prevention programs would combine all of these in some way. Every one of these components to come together for a comprehensive approach. Strengthening life skills, and so you think about the various training programs and perhaps EAP programs and so on that could be available to help people strengthen life skills and be more resilient. Building connectedness and social support, providing effective mental health services through insurance programs and so on. Providing crisis support and response. We're going to hear more about that later. And then I want to just, General Corelli brought up this idea of reducing access to lethal means. And there is a strong lobby in this country against having anything to do with trying to limit one's access to firearms. And firearms are the most deadly means that people take. And generally in the suicide prevention field, we've kind of backed away from that fight. But the fact is, when we know someone who's at risk, when we know someone is at risk for suicide, it is absolutely essential that we get them away from and keep them away from easy ways to kill themselves. And most people can get behind that concept, and I think that employers, as they carry weight in the political environment in this country, can help move that one forward as well. At this point, I want to turn it over to Dr. Quinnett.
This is a perspective from our institute. We're a training organization, as that so long as suicide remains a mystery, we have no responsibility to prevent it. But today you're learning that once we understand and begin to understand suicide, we can act boldly in good faith to save lives. Next slide. What do we know? Well, we know mentally healthy people do not kill themselves. And if recovery is possible, which is what we're preaching all across the country, then suicide is preventable. And the majority of Americans now believe that suicide are preventable, and that 86% of us believe that we should be investing in suicide prevention, and that's at the state, national, and hopefully the employer level. The health benefit utilization data rarely addresses suicide-related costs, and yet we know that 1 in 14 employees suffers from depressive illness at some point in their employment years, and that some of these attempt or die by suicide. So here's a formula I've done for some employers. If you have 100,000 US employees, and if they are like the CDC sample that was reported earlier, that is in terms of ideation rates, attempt rates, and completion rates, and planning rates, then in the next 12 months, and on average, you can expect 12 deaths by suicide, 20 or more if you have mostly male employees, or about 1 a month. The estimated cost to train 1 adult per family, you would spend about $1.5 million to train 1 adult per family to identify family members and loved ones at risk and get them care before they make an attempt. And the cost to train a professional would be that amount. Next slide, please. Where the return on investment, value minus investment divided by cost of the training investment of $2.5 million, you can see the math is pretty simple. And Sally referred to some of these more detailed costs. This was a rough and ready study done by the University of Idaho School of Business and Economics. Next study. But let's just say that training citizens and professionals does not save that life. This is the value of a return on preventing a non-fatal suicide attempt with an average hospital cost of over $6,000. So you're looking at training a citizen responder, and I'll tell you why this is important, because for each dollar invested here, you'd get about 300 some bucks back. So if we trained enough of our citizens to prevent non-fatal attempts, that would be 3.5 million or thereabouts, which is 10 times more than our Department of Public Health spends on youth suicide prevention for our entire state per year. The bottom line for risk managers in your businesses is that if you do not imagine that suicide risk may be present among your employees, you will be surprised by the next death by suicide. And as a CEO, you cannot detect, assess, manage, or mitigate risk you don't know about.
When I wrote Jumping into the Parade, it was, at the time, a cathartic experience for me to understand what had happened in my own life. I was a CEO of a company. As Sally had mentioned, I was in that role for about a decade. When the markets collapsed in late 08, 09, our cost basis was considerably higher. I lost $55 million. And I had always connected my works as a person to my worth, and I really wasn't sure what to do about it. I went on antidepressants and anti-anxiety medication in August of 09 after my first attempt at ending my life, and decided in August of 2011 that I was healed, that I was fine, and in November of 2011 I found out that the awareness that I had been given by well-meaning people, I'd never really integrated the tools, hadn't really done the work. I was off medication in New York and almost ended my life a second time. And I decided that I needed to really figure out what it was inside of me that had caused this, that I couldn't live like that anymore. Anyway, the last 3 years, I have rebuilt my entire life. I've rebuilt my entire perspective about how we live our lives as human beings. I didn't write my book really to tell my story. I wrote my book to help people understand that they're not hopeless or helpless. It was really never about my story. It was about their story and how you give people new perspective and new tools to get through life and to live life more powerfully. We all have the power to go change the world, and it all starts with a small group of well-meaning people, right? And let's go do it.
Part of the journey of recovery is one also of discovery and transformation. And for those people like Tim and others, I think that there's something really important that we haven't been talking about, which is the ability of people who have been through experiences to bring their resilience, their brilliance, and their insight into the workplace and into our culture. It was when I was a young person, I did attempt suicide twice, but one of the things that I remember very specifically was holding a gun and asking myself, based on all I'd heard before, based on my experience with mental health providers, with child psychiatrists, with other things, what was a more dignified choice for me? Was it more dignified to become a mental patient, or to kill myself? And I believe that right now, there are many, many people asking themselves this question. And as you know, 100 people kill themselves every day just in the US, 40,000 every year, million in the world all told. So to me, the work that I do through mental health advocacy and the development of services and systems is a lot of it driven by what I think we need as a culture, which is to promote the human dignity of people who are living with mental health conditions. Even though we have parity as the law of the land now, mental health parity, implementation of that is not coming forward. A lot of the new health plans, particularly if you're in a state where they do healthcare reform or they have health exchanges, are doing everything they can to manage and to get away from their obligations to provide good, consistent, and necessary mental health treatment. I'm really hopeful that you will really work to make sure that whatever you have in existence right now for your employees, and this is above and beyond employee assistance programs, is really going to meet the need that people have and the level of need they might have to get beyond their most difficult points, to live successfully with mental health conditions as most people do, and to be the best contributor that they can be within your company and agency.